Melissa? Okay, thank you. I'd like to welcome everyone, the public, to this meeting of the Health and Government Operations Committee. Our bill hearings for today, Thursday, March 4th. Please do not forward the Zoom link for the hearings. Staff will not allow anyone who is not invited to testify into the hearing. Please encourage people to watch the hearing on YouTube. Bill sponsor or designee is allotted 5 minutes to present the bill. 5 witnesses maximum will each be allowed to speak for 2 minutes. In support, please stay in the hearing if you are a witness until the delegates have had an opportunity to ask questions. After that, 5 witnesses will each be allowed to speak for 2 minutes in opposition and then also respond to questions. Please conclude your remarks when you see the timer finish. Members must remain present with your video camera on during the entirety of the hearing. And members are reminded to please ask only one question of one witness for each panel. If you have other questions, you may follow up offline. Please use the raised hand function to indicate that you have a question. We will begin with House Bill 1287, Delegate Lewis. Alcohol and drug counseling, alcohol and drug trainees practiced through telehealth.
Thank you so much, Mr. Chair. Esteemed colleagues, for the record, my name is Delegate Robin Lewis, here on behalf of House Bill 1287. I'm here to request your favorable report for a bill that will not only help Maryland respond to the COVID pandemic, but will also strengthen our state's healthcare delivery system. House Bill 1287 will expand access to mental and behavioral services through telehealth. We all know that a year ago, in response to the public health emergency, we initiated an expansion effort for telehealth services. Since then, a number of bills have come through this session that address telehealth and attempt to enshrine it in our healthcare delivery system and state law. This bill focuses on the supply side of telehealth delivery services, specifically for mental and behavioral health, that's targeted for folks who are experiencing substance use disorder and need very specialized counseling. The supply problem for substance use disorder counseling is very serious. There aren't enough trained and licensed experienced providers out there who can deliver those counseling services through any means, least of all telehealth. But one way to increase the supply of those specialized counselors is to enable trainees in that field to offer services over the internet through whatever device, whatever medium makes sense. As you guys all know, before the pandemic, we were struggling with a crisis of opioid and substance use disorder. And in the time since the COVID pandemic began, overdose deaths have actually increased. Reported depression and anxiety have increased. People of Maryland need help. Folks with substance use disorder need it just as much, if not more. One of the things the bill aims to do is respond to this increased need. Please note that there's nothing in this bill that changes the scope of practice for individuals who are in training to become substance use, drug and alcohol use counselors. Their scope of practice will not change. Nothing about the current system of delivery will change. The Board of Professional Counselors and Therapists actually recommend that we do this. To my knowledge, there is no opposition to this bill. And with that, I will just end with a common sense proposal and ask your common sense support for this measure. I'll end my remarks there and ask that we bring on the support panel. We have a slight change in our panel. Kim Wireman will be filling in for Dwayne Gould. Please make that note. So Kim Wireman, I'd like for her to go in this order: Kim Wireman, Paris Brooks, Patrick Maddox, and finally Howard Ashkin. Thank you.
Will those four witnesses please testify in that order?
Hi, this is Kim Wireman. Can the panel hear me?
Yes.
Thank you, sir. My name is Kim Wireman. I'm here representing Maryland Addictions Directors Council to express our strong support for HB 1287, providing alcohol and drug trainees, also known as ADTs, with the permanent right to provide treatment via telehealth. The ADTs were initially granted telehealth rights during the state of emergency. We'd like those to be made permanent. We as providers have a tremendous difficulty filling positions in the face of the opiate epidemic and the lack of trained counselors on the field. ADTs make up, according to the Board of Counselors annual report for 2019, about 40% of the addictions counseling field. So we can't deliver service without them. And what we've experienced is that telehealth, through the pandemic, telehealth allows us to reach so many people in need who are desperately in need of treatment and services and help. We also would like to remind the panel or say to the panel that ADTs can only work under COMAR, can only work at a licensed facility. They can't go into private practice or even work at a private practice. They have to be under the supervision of a licensed facility with COMAR regulations that specifically detail staffing and supervision. So we're not creating any addition to the scope of work for ADTs. Again, they're critical to our service delivery. The Maryland Addictions Directors Council did a quick survey in March of 2020 and found that about 9 of our providers from across the state delivering all levels of care employed 90 ADTs delivering service to just under 1,500 clients. Thank you for allowing me to express our strong support for ADTs to be given permanent rights for telehealth delivery.
Next witness, please. Thank you for your testimony.
Good afternoon, everyone. My name is Paris Brooks, and I'm currently an addictions counselor who has alcohol and drug trainee status. I work at Institutes for Behavior Resources located in North Baltimore, which provides comprehensive recovery services, including all medications used to treat opioid use. Speaking for other ADTs, we feel fortunate that IBR values our contributions and allows us to help individuals battling their addiction. While I currently maintain a trainee status, my functions are very similar to that of a licensed counselor. Typically, I conduct 15 to 30-minute sessions with each client to better understand and assist them with their substance use. The caseload that I currently have and the work that I do every day mirrors what a licensed counselor would do. When the pandemic began, IBR, like many clinics, attempted to find ways in which we could continue delivering services to clients while ensuring safety and privacy. Telehealth services have filled the therapeutic needs of many of our clients and are just as important to an ADT as any licensed counselor. Our clients who share personal information and have developed a bond with their counselor will suffer if we are unable to continue these services. The ability to see each client in person is just impossible given the size of my caseload and the rooms that we conduct sessions in, possibly being occupied by another counselor. For everything that I just discussed, I'm completely in favor of this bill, and my hope is that all trainees like myself are afforded the opportunity to continue making a positive impact in the lives of the clients that we serve. Thank you all and have a great day.
Thank you for your testimony from personal experience. Next witness.
Hi, can everyone hear me okay?
Yes, we can.
Okay, great. Thank you for the opportunity. Hi, my name is Patrick Maddox. I work for Project Chesapeake. We're a comprehensive behavioral health services organization who provides services across the state of Maryland. I'm our program development manager, and I have the opportunity to work directly with all of our substance use team, including our ADTs and other licensed providers providing substance use treatment. We at Project Chesapeake strongly support this bill. In the last year, some of the things that we have seen as an organization is increased access to treatment, increased retention rates, certainly flexibility in accessing treatment, and an overall reduction in barriers to treatment. We at Project Chesapeake employ a large number of ADTs. I know that the number of 40% of the workforce, we actually employ more than 40% of our substance use workforce as ADTs, and they provide tremendous value to our organization. In addition, we work with a lot of higher institutions of higher learning to provide internships and opportunities for folks that are going to school for advanced degrees who currently hold an ADT. We work directly with a lot of schools to bring those individuals into our company to be able to provide these services. Also, in my interactions with clients across the company, there's been a high level of satisfaction with the ability to connect through this platform with ADTs. And we know that we are pleased that the Board of Professional Counselors also support this. And I just wanted to wrap up by saying, as someone with lived experience, someone in long-term recovery, I've personally had experiences, very favorable experiences with ADTs who provided services in the past for me, and have gotten me to the place where I am today. And I'm very grateful for that opportunity. Thank you very much.
Thank you for your personal testimony. And now the concluding witness in favor of the bill.
Thank you. Thank you, Delegate Rosenberg, Delegate Kelly, Delegate Lewis, I'm sorry. My name is Howard Ashkin, and I'm here today as the immediate past president of the Maryland Association for the Treatment of Opioid Dependence, known as MATOD, and for Medmark Treatment Centers, a treatment provider in Hartford and Baltimore counties and Baltimore City. MATOD is a provider and advocacy association comprised of the majority of the state's 95 opioid treatment programs, or OTPs. Maryland OTPs provide comprehensive medication-assisted treatment with counseling for approximately 40,000 Marylanders with opioid use disorder. We're asking for a favorable opinion on HB 1287, which, as you've heard, will simply allow alcohol and drug trainee counselors, ADTs, to continue to provide telehealth counseling after the public health emergency no longer exists. We've submitted written testimony, so today I just wish to highlight that this bill permits the same telehealth allowances that were approved in April of 2020 by the Maryland Secretary of Health and the Maryland Board of Professional Counselors and Therapists. As previously mentioned, it does not change existing COMAR regs that define the ADT scope of service, scope of practice, place of employment, or their required supervision. Like MADC, MATOD members reported that ADT counselors comprise approximately 60% of the counselor workforce in OTPs. The Board of Professional Counselors, in their most recent annual report, mentioned that more than half of all alcohol and drug counselor applications were for ADT level, and that more than 62% of issued certificates and licenses were for ADT counselors. We've learned the provision of telehealth counseling during the past year has demonstrated not only its necessity, but its appropriateness and effectiveness. Telehealth has expanded counseling access and availability, improved treatment retention, and reduced systemic barriers and stigma. ADT counselors are essential members of the substance use disorder workforce, supporting thousands of patients who might otherwise be without care. So we ask for a favorable report on HB 1287, and we thank Delegate Lewis for introducing this important bill and for all of her work to improve our community's health. Thank you.
Thank you. Thank each and every one of you for your testimony. There is a question from Delegate Cullison.
Thank you, Mr. Chair, and I want to thank you, Delegate, for this bill and the panel. I think it's a wonderful way to help us address this really serious issue that we have. I just want to clearly understand ADTs. So prior to the pandemic, they work under the supervision of counselors, and they were doing in-person kinds of interactions. And then with the pandemic, we allowed everyone to do the telehealth And we've learned from that experience that the telehealth has been very effective with the folks who are being treated by ADTs. Am I correct in that sort of sequence?
Very much.
And I also heard the delegate say, so there's no change in what's being requested in this bill. It is simply continuing that level of service that was allowed during the pandemic, and I guess we're still in it, for when we get out of it. Is that correct?
That is
Correct.
correct.
Okay, wonderful. Thank you very much.
Thank you for your question. Thank you, Mr. Chair.
Thank you, Delegate Cullison. Delegate Saab.
Actually, Delegate Collison asked my question. Thank you, Mr. Chairman.
Thank you. The chair seeing no further questions. That concludes the hearing on that bill, on House Bill 1287. The next bill is House 1125. Thank you for your testimony. Thank you for the work that you do in the community, treating and assisting individuals with these mental health and opioid issues. Thank you so very much.
Thank you all.
Okay, House Bill 1125 is Delegate Beitzel, Prescription Drug Monitoring Program, Prescriptions of Opioids Notification Requirement.
Thank you. Thank you, Mr. Chair. I'm here. May I proceed?
Yes, you may. Thank you.
Okay, good afternoon, Mr. Chair and Vice Chair Pena-Melnick and members of the HGO Committee. For the record, I am Delegate Wendell Beitzel, and I am here to present House Bill 1125. I have in the waiting room a panelist who will assist me with this. Her name is Kristen Stevens, and she will join in whenever I'm completed in your letter. Maryland has seen a decline in opiate-related deaths due to vigilant action, but that has not been uniform across the counties in the state. We're not experiencing a rate of decline as other states where aggressive measures has been implemented designed to protect patients from addiction and overdose. The epidemic has evolved, unfortunately, as a state we have not. And since the passage of the HOPE Act, and I think the committee probably will remember the HOPE Act was passed in 2017. And this was a comprehensive behavioral health measure aimed at expanding treatment options to those with mental health and substance abuse disorders, and allocated more resources to reduce opiate dependency. In Maryland, MHAMD and the Maryland Behavioral Health Coalition worked with legislators throughout the session to refine various provisions of that act. We have failed to pass timely legislation to ensure best practices are followed across all areas associated with the crisis. This bill, HB 1125, the Prescription Drug Monitoring Program, prescribers of opiates notification requirements, is intended to address one area where we can make an impact. In an effort to provide checks and balances to patient education requirements in place, the proposed legislation will require a checkbox in the Prescription Drug Monitoring Program that the prescriber would need to mark no more than one time to notify the program that the prescriber had, that he had educated the patient on the risk of opiate use, made the patient aware of overdose reversal drug exists, and has dispensed or prescribed an overdose reversal drug. Benefits of this legislation include, most importantly, that measures that have been put in place to protect patients are being adhered to by prescribers. Further, it expands education to include an opiate reversal antidote and provides the patient access to the reversal agent. Additionally, the State Department of Health will have access to data that enables them to monitor whether or not prescribers are in fact following best practices as determined by the state. This issue touches me personally, since I had a son that was in a really bad accident about 20 years ago, and he was life flighted at University of Maryland medical center in Baltimore, and they addicted Oxycontin. I mean, they prescribed Oxycontin, and he became addicted, severely addicted, and it's been hell ever since for my wife and I and the family. And to make matters worse, and this is really almost unbelievable. He's had some complications as a result of that accident, and just over a little week ago, went in for spinal surgery to correct some problems in his neck. And when he came home, I asked him about what kind of pain medication had you received, and he informed me that he had been given a prescription for Percocet. You know, Percocet is like a class 2 substance that has it's more of a it's a stronger pain opiate medication than even hydrocodone. So I haven't had a talk with the doctor, but we did notify him that we're really concerned he's doing that, and indicated that it's a very limited amount. But I just hope beyond hope that he doesn't get addicted again or get back on the road to dependency from this medication. It would be extremely troubling. So I would like to mention that I have submitted an amendment that corrects a systematic error that was made during the drafting on this bill. The amendment clarifies that the prescriber notifies what the patient has received, not what the prescriber has received. So thank you for your time, and I urge a favorable report by the committee. I will now turn this over to Kristen Stevens. She's an advocate on these issues and has more knowledge and background than I do, and I've reached out to her for assistance on this bill. So if you allow her to proceed, I would appreciate it.
If I may, just a personal note before she proceeds, she may have more knowledge and background, as you just said, Ms. Stevens, but you have spoken to us from personal experience. Appreciate the situation your family is dealing with, and appreciate your sharing that with us today, Delegate.
Okay. Thank you.
Thank you. Ms. Stevens?
Make sure I'm off of mute.
Please proceed.
All right. Chairwoman Pendergrass and members of the committee, I would like to thank you for your time today, and also Delegate Beitzel, thank you for inviting me to testify on HB 1125, the Prescription Drug Monitoring Program Prescribers of Opioids Notification Requirement. I'd just like to let you know I'm here on behalf of the Strengthening the Mid-Atlantic Region for Tomorrow, SMART, as a member of the Health Working Group, and also as a concerned caregiver of a person who underwent a number of surgeries from 2019 to 2020. Just for background, SMART's working groups focus on veterans issues, workforce development, and healthcare. We're collection of community and industry leaders. We collaborate to identify and support the implementation of best practices throughout the Mid-Atlantic, which includes consistent legislative and policy action on various issues which have had the most profound effect in the region, including continuing addressing the ongoing opioid epidemic across the 4 states we support. We're concerned currently about the long-lasting economic impact on the region as a result of the crisis, especially now that we're 1 year into a pandemic. We've all seen the recent reports that show that opioid deaths are up 38.4% from May 2019 to May 2020 from the same period the year before. This is staggering when you consider essential work, which we've all been really big on. The Bureau of Labor and Statistics report identified 3 industries where this is most likely to occur, accounting for 43% of overdose deaths, and that includes construction, which saw a 3% increase this year in the opioid deaths. I did include some statistics in my submitted testimony that I would ask that you review for your reference, since I am short on time. But I would like to also add in that not only am I here as from SMART, but as a caregiver. And for me, I understand that we do have recommendations in place, but I know them to not be sufficient. Personally, I was a caregiver for a nurse of all people whose multiple surgeries resulted in multiple opioids being prescribed to her. And neither she nor I, upon discharge or before or after, were let known about the dangers of those. And this was after there was an oxygen incident in the hospital as well. So it was kind of the dual. So I'll stop since I ran out of time, but I'm absolutely happy to take questions. And once again, I really appreciate you being here today, or letting me be here today.
We thank you as well for your personal testimony. Are there any questions from members of the committee for either the sponsor or for this witness? Yes, Delegate Saab.
Thank you, Mr. Chairman. Thank you, Delegate, for bringing this bill. I think, the opioid pandemic has impacted many people in their lives, and the PDMP has been a successful program, and I think it's great to have it. My only question is, well, I understand that CDC has also guidelines and training and provides training tools for providers before they prescribe opioids to the patient, the risk factors with the patient, and some of them even require further testing to make sure they're not already addicted. My only question is, and I don't know exactly the dosage, where did the 50 morphine milligram or equivalent came from? My only concern is, are we infringing a little too much on our provider experience that will limit how much they should prescribe? Although they've already received training and they, they're pretty much well versed in that. I just want to make sure we're not tying their hands.
Yeah, I personally, I'm not a doctor, and maybe Kristen can answer this, but I would say, that my overriding concern is that that it seems and it appears that the providers, or the doctors and the providers that make these prescriptions to their patients don't seem to recognize the implications of what happens when people get addicted to this and how easy it is for them to get addicted. And just, I'll give you a couple recent examples. I went to the dentist just a year or so ago and had some implants. And when I left, he gave me a prescription. And I looked at the prescription. Of course, I'm more aware of these type of drugs and the opiate painkillers than maybe the average person on the street would be. But he gave me a prescription for hydrocodone. And I said, what are you doing this for? Why are you giving me this? And I said, don't you recognize what this can do to people? And he said, well, if you don't want it, don't take it. And so I'm wondering why, that he wouldn't inform the patient what this can do and ask them, you sure you really want this? Most of them don't even know that they're being prescribed this till they go to the pharmacy and they get it and they look and they go home and they have it. And don't take this in the wrong way, but I also had a shoulder surgery a couple of years ago, and I know the doctor really well. And after the surgery, I went into the pharmacy I didn't even look at the prescription, and it was hydrocodone. So I went back to him. I said, why are you prescribing this? And, I think at least you ought to tell people that you're prescribing it when you do. And so I know him well and he knows me, but he made off the cuff remark, oh, if you don't want it, sell it in the street. I mean, that's kind of thing that I think indicates that the doctors are issuing these prescriptions. And that Purdue Pharmacy and everything that's went through, and they're out of business and all the lawsuits. I just think we need to make a better effort to make sure these providers are not issuing these prescriptions and people getting addicted from them. There has been a drop, but I was in the HGO committee. I was on the HGO committee 2 years when I first came. This is way back then when this thing started. And there's a health officer from Harford County came down and gave a report to us. And she says 60% of the people that are addicted to heroin and cocaine and opiates are addicted because they were given prescription drugs by the medical providers. And so this is what I'm trying to address with this bill, that we do more to let people know when they're given this, that what it could do to them.
Thank you, Delegate. We have another question from Delegate Lewis Young.
Thank you, Mr. Chair. I'd like to address this question to Delegate Beitzel. Thank you for bringing this issue forward. Am I correct in understanding that neither your son in his recent experience nor you in your experience had a conversation with the prescriber while they were prescribing to say, I am prescribing you a drug that has addictive propensities, and I want to make you aware of that?
I can tell you on both occasions when I was given the prescription, I was not informed of it. It wasn't even mentioned until one time I went to the pharmacy and see what I got. And the other time I seen it in the dental office when I looked at the prescription. I can't tell you for certainty that my son had the discussion with his doctor. He indicated to me that he told him that he had been addicted to this before, and he still got the. Now, I can't say that for certainty, but I asked him that specific question. Did you tell the doctor you were addicted to prescription drugs? And he said yes. And he said, but the doctor said, this is just, I'm only giving you a short-term thing and you should be okay. But I can tell you, if he's not okay and he goes through this stuff again and he ends up going down the road to addiction again, I'm going to take and park him on that doctor's doorstep and say, here, you take care of him. I mean, this is really frustrating.
Thank you for that response. I'll get the information to you offline, but the reason I asked is I was a lead sponsor of a bill, I think it was in 2017, that required a conversation between the patient and the prescriber when these kind of prescriptions occur, to let them know what the nature of the drug, as well as to warn them about potential side effects. So I'll get you the information about the bill.
Thank you, Delegate Young. Thank you. Delegate Hill.
Thank you, Mr. Chairman, and thank you, Delegate Beitzel. And I'm sorry that you continue to experience what is really inappropriate, medical care in these situations, and understand how concerning it is. I don't know whether this question is for you or the other panelists, but I'm listening to your goals, which are to make sure that people are either prescribed less opioids or aware when they're being prescribed an opioid that it has addictive potential. But the bill does three things, and I don't see how that serves the goal. So the first, as I read it, is that it requires the prescriber to notify through the PDMP that they've been trained, and they have to be trained in order to be registered. So that's sort of asserting that I had the training that I was required to get for me to be able to tell you I had the training. The second is that over a certain dose equivalent that they give out a prescription for Narcan, or they give Narcan, but in Maryland, anyone can get Narcan without a prescription from a pharmacist, and Narcan won't prevent addiction. It is an overdose medication, so it doesn't really help someone who's taking too much and becoming addicted. And the third thing that the bill does is, actually, I thought I had it right in front of me. Prescribed or dispensed an opioid reversal drug, and prescriber may not be required to make the notification. Receiving education, aware that there's a reversal drug is available, and then prescribes it. I'm not clear how that. I don't see where that addresses what your goals are.
Yeah, the third thing there you mentioned is has prescribed. It states that it has prescribed or dispensed an opiate overdose reversal drug, and that this requires them to notify the PDMD of these things, but it only has to do it once. So I'm going to ask Kristen if she could provide further information on. I had assistance in putting this together.
No, that's fine. That's fine.
If Kristen can answer those things, I would ask her to do that.
I don't see what it achieves.
So the first part of it was actually where the amendment was put in. It's not the prescriber.
Excuse me, Delegate Rosenberg is muted.
We permit only one person to answer questions, so could I provide that answer to Delegate offline?
Absolutely.
Thank you.
No one's provided me an answer, Mr. Chairman. I haven't gotten an answer yet.
What I'm saying, since we only
Delegate Beitzel didn't answer the question. He said he was going to give it to the other panelists.
Okay, very briefly, please.
So the first line that you're referring to with the word prescriber in it, that's actually where the amendment went in. And so that's where we swapped it out for patient. So the checkbox is to notify that the patient was in fact educated. So it just tacks on to the already educated mandated education requirements. And then as far as the other two pieces go, the offer of the existence of the naloxone or the overdose reversal agent or whatever else is out there or potentially coming out. There are people that still don't know that they exist. And then, you know, the second piece of that is the offering of the co-prescription or the dispensing of it to make sure that, you know, if somebody is maybe leaving the hospital, they can pick it up there, or, you know, not everybody wants to go to a health department or something like that. And some people are very confused on how to get, you know, a hold of those things. People still say to me, you know, don't you have to be over 18 to pick it up when, you know, I've put something like that somewhere. So it's just those three parts together that we think are going to be the most helpful.
Okay,
Thank you,
thank you.
Ms. Stevens.
So it's about overdose and not preventing addiction. Thank you. Okay.
Thank you. The chair, seeing no further questions, no further hands raised, that concludes the hearing. And we thank both of you for your testimony.
Thank you.
Thank
The
you.
next bill is House Bill 962. Delegate Parrott, Washington County Nursing Homes and Assisted Living Programs, Essential Caregivers. Delegate Parrott.
Good afternoon, Chairman and Committee. It's wonderful to be with HGO here this afternoon. And I am going to try and share my screen. I have a quick PowerPoint on this local bill for just Washington County. Okay. Great. Hopefully everyone can see it. This is 962. It's a Washington County local bill. It's about nursing homes and assisted living programs. This is a picture of Lori Spencer. She's a daughter, and her mom, Judy Shape, is in a nursing home. And they're talking to each other through the phone and able to look at each other. Unfortunately, a lot of people in nursing homes don't have that ability to even look out the window like that. And they've had almost a year now without seeing their loved ones. And so that creates a problem. Studies are showing that social isolation it's now starting to be listed as a cause or contributing factor of death certificates. Many individuals, of course, in nursing homes have gone over 300 days in isolation or strict quarantine and not been able to interact with the family members or friends. And this bill doesn't do that. What this bill does is says they have one caregiver. Just this week, unfortunately, one of the folks who was going to testify on behalf of this bill, their elderly mother passed away in a facility care. She really cared, wanted to be here to testify, but of course needs to take care of items there. The picture here is just showing, this is actually an article that was an AARP, a 99-year-old Santa Cruz resident. She had gone 120 days in isolation and then went from very, very healthy to very unhealthy, almost, very, very quickly, and then ended up passing away later this year. And they attribute that in the article to her being socially isolated. So it's a huge problem. And there are ways to help address that. And one way is that one person, a caregiver, could be designated to people who are in the nursing homes. Several states have done just that this year. You can see Minnesota, Michigan, Indiana, New Jersey, South Dakota. They've all introduced policies and are allowing this to happen. Indiana Senate is right now trying to make it not just during COVID, but permanent. Other states have already made it permanent, this type of law. You see Ontario, Canada. But this bill that we're asking for is not the state of Maryland, but it's just Washington County. And this bill would allow Washington County nursing homes and assisted living facilities to create guidelines for a designated family member or close friend to enter the facility to help care and advocate for their loved one. And of course, it would just be one person who's designated to do that. It allows nursing homes to set their own guidelines for designating the caregivers' protocols required by the facility. This could include face mask, gloves, hand washing, making sure that the person coming in is quarantined, basically follow the same guidelines as their nurses already do. This is a local bill. it has local support. It was voted unanimously to pass by the Washington County Commissioners, and it was also voted unanimously with the Washington County delegation. The two letters are just shown here so you can see that. There are about 20, well, there are less than 25 nursing homes in Washington County, and the ones that we've spoken to have all supported this bill. Actually, today we have testimony, either written or oral, from Farney Keating Nursing Home and Kaufman Nursing Home. I know this is kind of a quick presentation, but I want you to support people who are older in Washington County. Please support local courtesy, and please vote for House Bill 962.
Excuse me. There are two witnesses who wish to
There we go.
There are two witnesses who wish to testify in support of the bill. We'll hear from those two witnesses, then have questions of the delegate and of those two witnesses, if there are any. Alex King and Dorothy Burt. Ms. King, please.
Hi.
Ms. King, you have the mic. You are in front of us. Please testify. Please go ahead.
Thank you. Hi, my name is Alexandra King, and I am the Assistant Director of Nursing and the Infection Control Nurse at Kaufman Nursing Home. I'm also a person that just watched a loved one give up while in isolation and had to say goodbye to her via Google Duo. So that was very hard. We have a real issue here in the nursing homes. This kind of isolation has shown to cause a wide variety of problems, including depression, poor sleep, accelerated cognitive decline, poor cardiovascular function, and impaired immunity. I've seen residents go from very good health to very poor health very quickly with this pandemic. And I've heard things from residents such as, what's the point of living if I'm not allowed to see my loved ones? We have a high number of residents with dementia that do not understand the technology of video chatting or why their loved one is standing outside. From an infection control standpoint, I feel confident that we can pass this bill and still keep our residents safe. Most of my residents have now gone over a year without hugging a loved one. As caregivers, we do everything possible here to be there for our residents, but at the end of the day, we're just not family. Watching our residents suffer from missing their families day in and day out is excruciating to watch and is definitely contributing to the caregiver strain with this pandemic. We try to explain what is happening to our residents, but they have never dealt with anything like this before. We do make exceptions for compassionate care visits and end-of-life visits, but sometimes it's too late. I have also witnessed on several occasions that a loved one comes in for an end-of-life visit, and then the resident improves after seeing a family member. That's amazing to witness and really shows the power of having family support. If you're against this bill, I strongly encourage you to go into a room for 24 hours and not talk to or hug your loved ones. And if you're still against the bill, try it for 365. Thank you.
Thank you, Ms. King. The next witness is Ms. Burt, Dorothy Burt. Is Ms. Burt in the?
She's with us. She needs to unmute herself.
Please unmute yourself, Ms. Burt. Well, are there any questions? While Ms. Burt tries to unmute herself, are there any questions for the sponsor or the first witness? Yes, there are. Delegate Lewis Young and then Chair Pendergrass.
Thank you, Mr. Chair. And thank you, Delegate Parrott, for bringing this bill forward. Well, I certainly agree with the intent of the bill. I have to question the wisdom of implementing it on a county by county basis because of some of the unintended consequences. The 25 facilities you listed in Washington County, I know of at least 3 that are also in your neighbor of Frederick County, Homewood, Summerford, Brookdale. So how do you tell a family that if you have a family member in Washington County, the rules are this, but in Frederick, they're different? And I know we have local courtesy, but this particular issue, I think, would be very complicated and confusing. Have you thought through that?
I do. And Delegate Young, I think that you have cross-filed a bill to make this a statewide initiative with someone in the Washington County delegation, Senator Quarterman. And, you know, that may pass. And if it does, you know, that'd be great. Then you wouldn't need this bill at all. But sometimes it's helpful with a big policy change to start it at a local level to see if it works or if it doesn't work and how that affects the nursing homes in the area. And so I think if this committee would like to start small, this would be one way to do that. Start by approving just the Washington County bill. And one thing that's different too is our bill has the support of the whole delegation, has the support of the commissioners, has the support of the nursing homes. And so this one does have support and is ready to go. But again, if the state one goes, that's wonderful. But if not, we would really like to see Washington County allow this to happen. And then we can take a look and see is it working or not in the future.
Thank you.
Thanks.
Chair Pendergrass and then Delegate Hill.
Thank you, Mr. Chairman. I have the folder here. I have the official folder, and I don't see the letter from the delegation in it. You may want to double check and see if it's been sent. It's also possible that it just didn't get in the folder yet, but we wouldn't even consider the bill until we had that. Second, as we all know, a local bill is only really a local bill after it's been done in one county. There's no local courtesy on a local bill that is groundbreaking. The first county to do it does not qualify for local courtesy. It's only when a bill is added on. So those two things are a problem. The real problem, of course, is the issues that were raised by Delegate Lewis Young. So, but to even think about this in subcommittee, we need the letter. So thank you.
Thank you.
Yeah, thank you. And just to answer that, we do have the letter that was actually part of the presentation, and I'm not sure why it hasn't delivered, but that'll be over there today. And as far as starting new policies at a local level, you know, that's how we start policies all over the time in the state. You know that Montgomery County, for instance, is the first county in the whole state that had speed cameras instituted. And I could point to several different examples where new policies are starting just one county at a time. And I think this is a good example of a case where this could be a good place to start. And I would encourage the committee to please accept this and treat it as a local bill, understand that it is a change, but that we have total support in Washington County. Now, there were some people who objected to the bill, but you'll read those testimonies. None of them are in Washington County. And even though they do, some of them represent some of the nursing homes in Washington County, even today, their members in the county actually support the bill. So I think that would be one way to start just here in the county. Thank you.
Thank you. Delegate Hill.
Thank you, Mr. Chairman, and thank you, Delegate Parrott, for trying to wrap your thoughts around this really challenging issue. I'm looking at this bill and the other ones that we've had, and here's where I'm confused. You've got support from the nursing homes. They can already establish a policy with a caregiver. The question becomes, how does a policy that a nursing home has about an essential caregiver stand up if there's a state of emergency order? I don't think that the fact that they have a policy means that they can ignore a directive from the governor or the president or anyone else. So I don't see how that would change anything in the pandemic. If there's a law or ruling that comes down that says, or directive that you can't have a visitor, having a policy that establishes an essential caregiver as a visitor. So explain to me how this would play out in our pandemic situation, please?
Sure. This bill is modeled after a Minnesota bill. And so that was instituted during COVID. And it specified that not just anybody, no visitors, but it's a caregiver who's designated can come in. And the nursing homes at that point had to do that. You know, one question at the very beginning, which was a really valid one, is why don't they just do it right now, the nursing homes? And I tell you, the reason why is liability. They're very concerned about getting sued, having kind of gone off on their own and started this policy. If in Washington County, we have this bill that says they must do that, well, then the liability goes away. They can point to the law and say, well, this law forced us to allow a caregiver, and that liability question goes away for the nursing home themselves.
Thank you.
Thank you.
Thank you.
Thank you. Is Ms. Burt ready to testify?
She still needs to
Not.
unmute herself.
Can you unmute yourself, Ms. Burt? Well, we have one more witness. We'll give the courtesy to Ms. Burt if she can unmute herself. We are done with those who are testifying in favor of the bill. We have one witness who wishes to testify favorable with amendment, Elmer Dengler. Mr. Dengler.
Yes.
Can
Hi
you
there.
show us yourself on the screen if you can, please?
Oh, hang on a moment. There. There you
Okay.
go. Hi there. Yes, I would very much like to say any effort at all done in this is very important. I deal with a mother who is really, she's going on 99. She's been in a nursing home 10 years. The net effect with dementia causes a rapid decline of a person if they do not have regular interaction with family members. I have seen that. I've nursed her through these 10 years. The last 2 years have been very difficult, but I was able to keep her functional, relationally, not a cost to the facility in terms of additional care or additional drugs. And this last year with the isolation, I have essentially lost her. She doesn't know me anymore. I'm been allowed in through compassionate care visits, but frankly, those simply don't make it. It's too late. And the anxiety and the stress within the workers is very, very strong. And any way we can ease those things, reduce cost, and help the families, and most importantly, help the person who's in this dire situation, I think you have to figure out a way how to do it. Whether you do it in one county or whether you do it statewide, whether you do it as an overall law that applies uniformly everywhere, it has to be done. It's being done in other states, and it makes a big difference in quality of life and can be a cost saving and a drug reducing measure. I really thank you for considering any and all forms of a bill that establishes caregivers. It's really very important that that be done.
Thank you very much for your personal testimony. We appreciate it very much. Are there any questions from members of the committee? There are none. Ms. Burt, I'll give you one last chance. Okay, we appreciate your coming down, but we can't hear your testimony if you can't unmute yourself, unfortunately. That concludes the hearing on that bill, Delegate Parrott's bill. We'll now House Bill 1033, Delegate Cullison, Office of Healthcare Quality, Influenza Virus Immunization, Education and Information, Assisted Living Facilities. Delegate Cullison.
Had to unmute. Thank you very much, Mr. Chair, Madam Chairman, and Madam Vice Chairman, and members of the committee. Thank you for the opportunity to present a very straightforward, clean bill that has no opposition, that can be done with current resources, that's supported by some very important groups in terms of those who are looking out for our elderly and senior citizens, including the Maryland Senior Citizens Action Network and Maryland ARP. The bill simply builds on current law, which says that in our assisted living facilities, they must provide information to the residents about the availability of the flu vaccine and why the flu vaccine. It seems pretty straightforward and something that we should be doing. And in fact, those requirements are in place. And so therefore, it's not really a burden to any of the facilities that are already doing it. And for those who aren't, it will heighten their awareness around the need to provide this kind of information to its residents. The Office of OHCQ would be in charge of enforcing this through their regular processes. They would not need to add any additional visits or any surveys. They would simply check at the facilities to make sure that there is posted information and that they're about the flu vaccine and the importance of taking it, and make sure that they know when they can get it and how they can get it there at the facility, because it is provided there. And for when it's not, that information is not being provided, then OHCQ would just alert the facility to make sure that it's done very quickly. It's meeting the requirement is very simple. The CDC has some easy prints that they can order just to put up around the facility. And they can work out the education method that really works best for them. You know, I was really surprised to learn that only 57% of Marylanders get the flu vaccine in any given year. And it's particularly risky in folks of a certain age, including myself, who had to get the double senior dose of the flu vaccine this year. But we see what can happen in those facilities when the residents don't take advantage of the flu vaccine. There's especially high risk for severe illness and death that's related to the flu in long-term care facilities. So we are simply asking that we be very intentional and deliberate in providing this kind of information to our residents and make sure that they have all that they need in order to make sure they make informed decisions about taking the flu shot. So with that, I thank you very much for your consideration of the bill. And on behalf of some of our senior residents living in long-term care facilities, I ask for your favorable report. Thank you very much.
Thank you, Delegate Cullison. Are there any questions of the delegate? There are, yes, no other witnesses. Delegate Krebs.
Just quickly, did you say that already the assisted livings provide the flu shot there on site?
Yes, they do.
So all of them do. Are they
Yes.
required to do that?
Yes.
Well, it would seem like this is a no-brainer that they'd want to inform them of it, but thank you.
Well, I guess I thought so too, but apparently it doesn't always happen. So
No, it's nice to know that they provide it. Thank you.
yeah, thank you.
Chair seeing no further hands raised, virtually or otherwise. That concludes the hearing on House Bill 1033. And we now turn to the fifth and final bill of the day. Delegate Kelly, House Bill 1040, Health Occupations, Pharmacists, Administration of Vaccinations. Delegate Kelly.
Thank you, Mr. Chairman, and members of the committee. As the chairman just said, House Bill 1040, Pharmacist Administration of Vaccines. This is a bill that you heard last year. Just want to remind you that in no way does this bill deal with parental consent for vaccines. So please take that off the table. What this bill does do is it seeks to put into the state law what is now a current federal order from last August, expanding the ability of pharmacists to administer childhood vaccinations. So this is another one of those sort of how do we even try to put the genie back in the bottle situations, similar to the one we're seeing with telehealth. There's a federal order already that allows the pharmacists to administer childhood vaccinations. The Biden administration, as well as the Trump administration, have both recognized that pharmacy access to vaccines is not only safe, but also essential for getting us through the COVID pandemic. Those of you who know me know there's not a lot that I agree with the Trump administration on. So this is a really notable point here. And it's for two reasons, right? Not just for administering the COVID vaccines, which should be approved for children this summer and fall, depending on the age range, but also for those regular childhood vaccinations. Those of you who follow healthcare, which is everyone on this committee, knows that we have fallen behind on well child visits. And as a result, our childhood immunizations are down, and we need to do everything we can to get them up. A report from Blue Cross Blue Shield found that 40% of parents reported that a child has missed a vaccination in the last year, 40%. And people have missed their well child visits for a lot of different reasons. But in addition to that, the public health departments, the local health departments that do vaccination clinics for kids when they go back to school, that program didn't happen as robustly this fall because, of course, we did a lot of virtual school. So a lot of the local health departments scaled back their clinics, and some of them, including Prince George's County, have just halted their childhood vaccination programs. In addition, from Medicaid data, we found that at least 20% of children aged 3 to 6 and 40% of children aged 12 to 21 have missed their well child visit in the last year. That's from 2020 data. So again, we have a lot of catching up to do, and it's really important. I want to give the rest of my time to my panel. I just want to note that you're going to see an opposition letter from the HGAU. I spoke with Pat O'Connor about this last night. Her concerns are that the bill is written too broadly and that we should limit this to the 2 years running concurrently with the federal order. I think that's a way we could move forward and then potentially study how this is working while the feds are allowing it to happen. And that will potentially help us address some of the concerns that are going to be raised by MedChi, including the problems that exist with Immunet. So I'm happy to take this approach. It's very similar to the approach that we've taken with that other, how do you put the genie back in the bottle issue of telehealth. So with that, I will save my last 1 minute and 45 seconds to share with Jill McCormick on my panel. And urge the committee to work with me to find some way to move forward on this really important issue.
Thank you, Delegate Kelly. Ms. McCormick?
Thank you, Mr. Chair. Can you hear me all right?
Yes, we can.
Great. Good afternoon, Mr. Chair, Chair Pendergrass, Vice Chair Pena-Melnick, and committee members. And thank you for the opportunity to speak in support for House Bill 1040. I'm Jill McCormick, and I'm the Director of State Government Affairs at the National Association of Chain Drugstores. It's nice to see you all again this year on this issue. House Bill 1040 will provide families with another option to have their children vaccinated at their local pharmacy for age-appropriate vaccines beyond the flu. This bill does this by aligning Maryland state law with current practice in the state and nationally. Approximately 800 pharmacies operate in Maryland, many with extended evening and weekend hours, offering really unparalleled convenient access to childhood vaccines for busy families. So how does House Bill 1040 align Maryland law with current pharmacy practice? Well, in August of last year, the U.S. Department of Health and Human Services recognized the adverse impact COVID was having on the healthcare system, but also, and notably, and in writing, both the qualifications and the experience of pharmacists as vaccinators. When they issued the Third Amendment to the PrEP Act, the amendment superseded state laws and authorized pharmacists to administer any ACIP/CDC or FDA authorized vaccinations to children aged 3 years and above. And they would be administered according to the CDC's age guidelines for each vaccine. Following this, the Maryland Department of Health recognized the amendment. However, a change in statute is necessary in order to maintain this option for families in your district once the COVID state of emergency ends. And that's what HB 1040 is intended to do. I'd like to just focus today on a few key points in answer to concerns that are routinely raised by our physician partner vaccinators about patient safety and the importance of continuity in medical care and routine medical care. One, pharmacies have a proven track record of safely providing vaccines to both children and adults in your state. It's been a well-established practice in Maryland and nationally well before COVID and the PrEP Act. In fact, since 2015, Maryland pharmacies have provided more than 3 million vaccines to your constituents, including children and adolescents, without serious incident. I trust that you will agree that this stat strongly supports the fact that pharmacies provide safe and accessible vaccines and that patients trust and depend upon them for that access. Two, the stats also support the fact that pharmacies have standards in place to ensure the patient is a good candidate for the vaccine they are seeking, including the standard use of a patient questionnaire and medical screening tool. They follow the same evidence-based protocols and vaccine guidance other providers use. For example, our protocols, not to mention our knowledge, would not allow us to provide a vaccine to a seriously ill patient or a patient with a pre-existing medical condition that makes the vaccine inadvisable. Plus, as PharmDs, pharmacists really are the experts on medication and vaccine and their side effects and possible adverse interactions. Three, as required by Maryland law, pharmacies collect physician contact information from patients and must make at least one attempt to notify the physician when they are vaccinating one of their patients. In answer to the medical lobby's concerns about care coordination, we believe this notification gives a physician a unique opportunity to reconnect with their patients who may have strayed from their medical home. We also report all vaccines to the state's immunization registry, serving as a backup for physicians to reference. Lastly, I respectfully ask you to keep in mind that many patients don't have a primary care physician or a regular pediatrician, so pharmacists can and do help bridge gaps in patient care. They are extremely experienced in communicating with primary care providers, making referrals, and counseling patients on the importance of routine medical care, including educating parents on the importance of well-child visits. We want to support the entire healthcare team. Thank you for your time.
Thank you, Ms. McCormick. Kaylee Locklear.
Good afternoon, honorable committee members. Kaylee Locklear here on behalf of the Maryland Chain Drugstore Association. COVID has brought the issue of immunizations into the spotlight, and it is clear now providing access by using pharmacies in conjunction with other healthcare providers just makes sense. And I quote from the Department of Health and Human Services, "The decrease in childhood vaccination rates is a public health threat and a collateral harm caused by COVID-19. Together, the United States must turn to available medical professionals to limit the harm and public health threats that may result from decreased immunization rates." They continue, "Pharmacists are well positioned to increase access to vaccinations, particularly in certain areas or for certain populations that have too few pediatricians and other primary care providers, or that are otherwise medically underserved." To address the Attorney General's letter, it was always our intent to follow the PrEP Act, which says for ages 3 to 18, the vaccination must be ordered and administered according to ACIP's standard immunization schedule. We're glad to add that in via amendment to alleviate the concern for children. However, FDA authorized and approved must stay so pharmacists can immunize for COVID immunizations as they come out and receive approval. We are open to a study that is referenced in the letter, but providing and then taking away access just really doesn't make much sense. Finally, and you heard this earlier, 2 Maryland County health departments have completely terminated immunizations for the public because of COVID immunization focus, and other counties have severely restricted access as well. From a Kaiser study, we also know 45% of Maryland children do not have a medical home, and many do not have a pediatrician. We strongly support giving Maryland families permanent vaccine access at a pharmacy, and we urge a favorable report. Thank you.
Thank you, Ms. Locklear. Lorraine Diana. Ms. Diana. Is Ms. Diana in the waiting room?
No, she should be with us. She needs to unmute herself.
I'm unmuting. Thank you.
Okay, great.
Yep.
Thank you. We can hear you.
Okay, great. So good afternoon. My name is Lorraine Diana. I'm a nurse practitioner and I'm representing MNA today. And I thank you for this opportunity to testify. This bill, HB 1040, is about access to care. It affords parents another option to obtain vaccinations for their children in places at times that might suit their work schedules or their children's school schedules better than more traditional options. Dealing with COVID has called attention to the many gaps in access to care for populations throughout Maryland, particularly the inner cities, Western, Southern, and Eastern Shore Maryland, leaving many people with few good options to obtain needed preventive health care and vaccines. Allowing pharmacists to administer vaccines to children ages 3 to 18 during the COVID crisis was key in ensuring children did not miss critical vaccines while provider offices were working on abbreviated schedules or seeing patients via telehealth. And you just simply cannot administer a vaccine via telehealth. Judging from the number of telehealth bills before this legislature, telemedicine is with us to stay. Pharmacists have been administering vaccines to this age group in Maryland for 7 months, and this policy has proven to be both safe and efficacious. Dealing with COVID has proven we can find innovative solutions to providing healthcare. Pharmacists have both the knowledge and expertise to administer vaccines to children. Expanding the pharmacist's role as part of the preventive medicine healthcare team can be part of the solution to help ensure more pediatric patients have access to vaccines. Thank you for your consideration of this testimony. We urge a favorable vote on this bill.
Thank you. Final witness in support. I hope, my regrets if I don't pronounce your name accurately, Olamide Banjo.
Good afternoon. And thank you for having me on today to testify in support of this bill. As has been mentioned, this really is about providing access to care. As a pharmacist, I've had the opportunity to work in several different patient settings, to work with patients across the age spectrum. And one thing I can say is that pharmacists are perfectly placed to provide this valuable immunization service to our pediatric patients. We have received extensive, at least 6 years of in-classroom training to be able to become pharmacologic medication experts and more so experts in patient care. In addition to that, we also have years under our belt of practical training that allows us to, not only serve patients in our community, but continue to make sure that we refine our processes and work in collaboration with other healthcare providers. So our goal today is not to usurp the role of, pediatricians or any other healthcare provider, but it's to work in conjunction with those providers to make sure that our patients are not being left behind. As pharmacists, we're very patient facing. We have, direct contact with parents, guardians. Our hours of operation allow, parents to not have to think about, the sacrifices they would have to make in order to take their child in, for an immunization. And it allows them to then be able to catch up with any kind of missed doses and also take their child in for a well-child visit with their pediatrician. So we continue to urge parents to do this. Again, our goal is not to take over that role. And more so, we cannot discount the impact of pharmacists on communities of color and underserved communities. We are out there and, we've been able to provide this service so far. We've seen the impact of it in our community, and we would like to continue to be able to provide this valuable service. Thank you.
Thank you, Ms. Banjo. Are there questions for any of for the sponsor or for any of the 4 witnesses who have testified in support of the bill? Delegate Johnson, followed by Delegate Belcastro.
Thank you, Mr. Chairman. And for any of the members of the panel who are best to answer the question. Last year, this bill, or a form of this bill, came before our committee. And I know HPV was a big issue in that bill. Well, I I see that the CDC's recommendation of immunizations falls beyond that of what they require for school, and it also adds the HPV vaccine, the immunization, in ages 3 to 18. That is kind of outside the window of cervical cancer for females. So my question is this bill about accessible vaccinations, or is this bill more about the HPV?
I'm happy to jump in there. This bill is not about HPV. It's about access to vaccinations. We have to follow the CDC's age schedule on vaccinations. So we would not be giving HPV to a person who is not age appropriate according to the CDC schedule. We are not allowed, no provider would, and that is our intent, and that is why we reference CDC in the legislation. If it needs to be clarified, we're happy to clarify that.
Okay, just a follow-up in MedKai's letter.
Very briefly.
Yes, CD's recommendations for immunization schedule for persons 3 to 18 includes the HPV. And this would also include pharmacists giving vaccines without prescriptions. They could administer to children or adults vaccines approved through the FDA. Is that correct?
Correct, according to the CDC's age guidelines only, and only with the consent of parents.
Okay, thank you very much. You can talk further offline. Delegate Belcastro.
Thank you, Mr. Chair, and thank you to the sponsor for bringing this bill forward. My question is for Ms. Locklear. Ms. Locklear, I utilize chain pharmacies monthly, and one of the things that I constantly notice is that there's one pharmacist behind the counter. They are often very busy. They have a lot that they need to do. And I'm concerned about the additional workload that this is going to put on them. Just last month, when I was in a chain pharmacy, the pharmacist had to be pulled away from their work to do an immunization, and they were visibly frustrated at the amount of work that they had to do. So what is being done by the chain pharmacies to address the additional workload that this bill would put on the pharmacist should this pass?
Well, so I can't speak to that particular occasion, but thinking back to when I went and got my flu shot at a chain pharmacy, you stand in line and wait in your turn, whether it's filling a prescription or otherwise. And so to answer your question about how we mitigate workload, we have an entire industry. Our pharmacists want to be able to do this and provide this service and practice at the top of their license.
Thank you. I'll follow up offline.
Thank you. Delegate Saab.
Thank you, Mr. Chairman. Actually, Delegate Belcastro made a very good point. I mean, I do have a lot of issues with this bill, because that's how mistakes are made when pharmacists are, we're asked to do more with less, and then we keep adding to them. But my real concern in this bill, one of many, and I'm not going to get too much into details, but why is it in the bill that says that the bill also specifies that the pharmacist is not required to inform the individual's primary care that the influenza vaccination has been administered? So why are we keeping the pediatrician, the doctor or the provider that is monitoring the care of that child out of the loop?
I'm happy to answer there. Delegate, first to answer your concern. I mean, I think I'm going to go back to, we gave 3 million vaccines to Marylanders in the past 5 years safely without incident. So I think that goes to workload and the first issue that you brought up. We would not, and on your second question, can you just briefly remind me what it was? I'm sorry, I lost my train of thought there. Your question.
Yeah, so my question is, why are we leaving the pediatrician out of this? Why is
Oh, that's right.
not required to inform the primary care provider that the vaccination, the influenza has been administered?
That was a compromise that was made when the last expansion passed several years ago. we actually do inform the physician whether or not it's flu or another vaccine, even though that exception is in the law. And we'd be happy to have that tightened up to make it all vaccines. We do that routinely anyway. And in addition to informing the primary care physician, if they have one, if the patient has one, we also report every vaccine to the state's immunization registry, which is also accessible to other providers. So I hope that answers your concern.
Thank you, Mr. Chairman. I'll follow up with the sponsor a little bit later, more on the compromise, but I appreciate the opportunity to ask. Thank you.
Thank you, Delegate Saab. Delegate Hill.
Thank you very much, Mr. Chairman, and thank you to the bill sponsor. I think this is a question for all of the industry representatives, chain and non-chain, that you will need to follow up offline. I would really appreciate if you could get to me in the committee the numbers of vaccinations to children that you've done in the past 7 months, what types of vaccines and what age groups, since this pandemic exception went into place. So you've had the ability to do it. I'd like to actually know what that experience looks like in terms of ages and types of vaccines, and appreciate getting that information. Thank you.
Okay. That doesn't require an answer from any one individual because you're asking of them all. Thank you very much. Okay, that concludes the witnesses in favor. We will now hear from 5 witnesses who oppose the bill, speaking unfavorable. First is Sarah Cusack, then Megan Montgomery, Joe Fitzgerald, Julie Sharp, Pam Casemeyer. Ms. Cusack.
Good afternoon. I want to thank the chair, the vice chair, and committee members for letting me testify today. I come before you as a parent and a pediatric physical therapist. I'm actually a little more concerned about the bill hearing the testimony. Children are not vaccinated like adults. They have a complex, complicated, recommended schedule from the CDC. 4-year-old children who would be impacted by this bill, according to the age-appropriate recommendation, should receive vaccinations for measles, mumps, rubella, chickenpox, diphtheria, tetanus, pertussis, polio, and influenza. I'm raising a child with an autoimmune condition. She cannot take all of those at one time. Her immune system cannot handle it. So the bill does not specify that pharmacists would only be vaccinating perfectly healthy children. And you heard in the support testimony several times that the pharmacist would follow the age-appropriate schedule. That's not how it's supposed to be done. The CDC put out a recommended schedule that was always supposed to be partnered with the expert assessment. So when you go for a well child visit, the pediatrician does a full physical examination, they have the full medical record and the full vaccination record. If this bill were to pass, pharmacists would be seeing children with multiple allergies, autoimmune conditions, cancer, children who have had previous adverse reactions to vaccines, such as passing out, seizures, anaphylaxis. And you need to consider that children as young as 3 may be having those first adverse reactions, like a seizure or anaphylaxis, in a pharmacy setting. And lastly, as a pediatric physical therapist, I can tell you it takes a special skill set to work with 3-year-old children. And I'm concerned that pharmacists are a branch of healthcare that did not choose direct patient care, and they did not choose to work with pediatrics. Thank you for your time.
Thank you. Ms. Montgomery.
Good
Megan
afternoon.
Montgomery. Thank you.
Good afternoon, Delegate Rosenberg and members of the committee. I come before you testifying on behalf of the Love Maryland PAC and opposing this bill. As several of the questions from delegates earlier in the testimony or earlier in the hearing stated, pharmacies right now are overworked, they're overstressed, and frankly, they're over-incentivized to put profits over people. I can tell you that since the beginning of the pandemic, my local pharmacist, which happens to be a chain pharmacist, has made mistakes on my injectable medication twice. If this was insulin, and if it wasn't that I could have seen the label and know that this was the wrong medication, I could have died. And I think we need to be very, very careful permanently granting pharmacists a role in providing medication to children in which the parents do not often see the vial from which a dose is administered. So for example, for flu vaccines, they cannot be delivered. There are flu vaccines with egg protein. It cannot be delivered to children with egg allergies. What if they grab the wrong vial? Who is there to double check that work? Finally, I want to talk about the administration of the vaccine itself. As Ms. Cusack mentioned, children at the 4-year-old well child visit are given multiple vaccines. This often involves having to be held down and having to have their clothing removed. So I want to think about a Walmart setup, which is 2 chairs with a curtain. How is that going to happen? Are they going to do this on the floor? Are they going to get out a folding table? Do they have the staff to provide 2 staff to administer 1 set of vaccines? And finally, as was brought up, I'm very concerned that this will actually cut down on the number of well child visits because parents won't have to go to those well child visits to get vaccines. Thank you so much.
Thank you. Ms. Fitzgerald, Joe Fitzgerald.
Hi, good afternoon, Chair, Vice Chair, and the members of this committee. Thank you for allowing me this opportunity to testify today. I am a registered nurse, and I'm also a grandmother of 3 grandchildren that this bill could impact them. Since pharmacies have started giving the flu vaccine, there has been a tremendous increase in the shoulder injuries due to an inappropriate placement of the needle, which has resulted in damage to the ligaments, tendons, and nerves, causing lifelong injuries such as paralysis and chronic pain to an upper extremity. If this injury is happening to adults who are willing participants, what is going to happen to a child who is not a willing participant, who is uncooperative, wiggles around, and is oftentimes screaming, and many times requires to be restrained by 1 or more individuals to give a needle? I personally had my own experience with my child. My 5-year-old passed out after a vaccine. When he came off the exam table, he fell over, knocking his 3-year-old brother to the floor. And it appeared that my 3-year-old, because he was chop blocked from the side, had a broken leg. So meanwhile, my 5-year-old was passed out on the floor while my 3-year-old was screaming and crying. It took 40 minutes for the doctor to recover my 5-year-old's blood pressure. But we were in his office for almost 2 hours. And during this time, the doctor had to assess the 3-year-old's leg while monitoring the 5-year-old. Fortunately, I was in a doctor's office with the doctor and other medical support staff because in an instant, we had 2 emergency type situations going on. So I cannot imagine this happening in a Walmart. I'm assuming that they would just call 911. Pharmacies are not set up with private rooms and with the necessary medical equipment that they may need that's necessary for an emergency situation. I also cannot emphasize enough the importance of the physician's assessment directly prior to an invasive medical procedure. This is why we have pediatricians. They specialize in assessing children and the appropriateness of receiving a vaccine listed on the CDC recommended vaccine schedule. Therefore, I do oppose this bill. Thank you for taking this into consideration. And I also want to thank you all for serving the state of Maryland.
Very kind of you. Pam Casemeyer.
Hello, Madam Chair, members or Mr. Chair, members of the committee. I'm here on behalf of the Academy of Pediatrics and MedChi as well, and the federally qualified health centers here respectfully in opposition to this legislation. I wanted to raise a few points and respond to a few. I think we need to be very careful. They may have changed the rules during COVID, but we've changed the rules on lots of things during COVID. And I think that in and of itself does not warrant the permanent alteration. I think you've heard a lot of compelling testimony from the other opponents, but what I would say is there is tremendous is a lot of misperception amongst parents that if I got my child vaccinated, that's all I really needed to do. You're bringing this down to age 3 years. Right now, they can prescribe to age 11 and above with the prescription. Prescriptions can be electronically transferred. So there's not a lack of access, but more importantly, Maryland, until the COVID issue, Maryland's had one of the highest vaccination rates in the country. We're around 80, 90%. We aren't not vaccinating our kids. But it is the time when they get their vaccines, they also get their child readiness evaluations, disability screenings, other kinds of healthcare issues. In the adolescent population, you all have been dealing with a lot of issues around adolescent mental health issues and the like. If you take that out of the comprehensive healthcare delivery system, when there isn't an evidence that, aside from COVID, where everything's been upended, we've had vaccine difficulties, our rates don't show that. We're going to bifurcate medical care in a way that's not, is going to have a lot of unintended consequences. And so with that, we'd respectfully request an unfavorable report.
I think we may have lost the chairman briefly.
I think that Delegate Rosenberg was disconnected.
Yeah, it looked like everything, the audio went down for everyone for a second.
Yeah. Is he back?
This is Pam Casemeyer. There's a Dr. Rebecca Carter who had been let into the meeting to testify that hadn't been called on.
So Ms. Rebecca, may we have your testimony?
Absolutely. Members of the committee, thank you for allowing me the opportunity to voice opposition to this bill on behalf of the Maryland chapter of the American Academy of Pediatrics. My name is Dr. Rebecca Carter. I'm a general pediatrician in the state. And as you can imagine, vaccination is an essential component of pediatric preventative care, and this bill threatens to inadvertently separate the pediatric patient from their medical home. So it's therefore not one that our group feels is in the best interests of Maryland children. Now, the medical home is an essential component of primary care. It allows us to utilize well child visits to administer vaccinations, but also importantly to address chronic medical conditions, to screen for developmental and mental health concerns, to address sexual health in our teenage population, and to ensure adequate services are in place. So as one example, last week I was scheduled for a 4-year-old well child visit and a child who hadn't been in our office since age 2. His mom right away said that they were only there to receive their vaccines, but in the course of the visit, I identified a new heart murmur that required further evaluation and recognized that he had significant developmental delays, including concerns for autism that are going to require therapies and further evaluation to make sure he has his services in place as he begins kindergarten. We also addressed her transportation needs to ensure she had the ability to pursue treatment plans. And very likely, had she received her vaccinations elsewhere, this important need for vaccinations would not have been identified. And then in other instances, we have teens where their presence in the office for the sake of vaccines allows us to counsel on such important mental health needs. And we know that that's even more essential as we see increased rates of depression during the pandemic for this age group. So in the national context, we know that the COVID-19 pandemic has made a more urgent need for us to extend accessibility. But given our high rates of vaccination in Maryland, we do not believe that accessibility has a problem the way it has been nationally. And we think that this inadvertently introduces new compromises for child health care. We also know that Immunet is not a perfect tool for our state registry, and we often are left guessing which vaccines have been received when they're obtained away from our office. So if we believed this bill would advance the health of Maryland children, we would be first in line to support it. But as it stands, we think it represents a solution in search of a problem, and we wish to maintain the structure of the medical home. Thank you for your time.
Thank you, Delegate, and thank you, Madam Vice Chair, for pinch hitting for me while I had a power outage. There's a question from Delegate Kelly, the sponsor.
Thank you, Mr. Chairman. And I never like to ask questions on my own bill. And I'm sorry, Ms. Casemeyer, I haven't talked to you about this offline before the hearing, but does the AAP oppose the federal order is my first part of my question. The second part of the question is, in the context of the federal order, are you opposed to studying what's happening with pharmacy access for children while it's happening? We heard a lot of conjecture of what might happen and how bad things could be and how terrible it could be. Would you be opposed to, since it's happening, studying it and seeing how it's working?
So, I mean, I'll have to ask my clients. I can't imagine they would be adverse to studying things at all. And I think some Delegate Hill already asked about numbers. But I don't think you heard us say they can't give the shot. There's just so many other implications connected to all of that. And do we oppose what they're doing now federally? It's hard to oppose anything to get us all through COVID. But getting us through COVID and changing certain dynamics are very different parameters. They are already able to give down to the age of 11. And I know it says with the prescription, but prescriptions can be electronically submitted. So it doesn't require the parent to have to go to the physician's office to get the prescription. If there's for some reason, the physician works with their patient to do that. So I think, sure, we can talk about anything, but now we're down to age 3. So they're very different circumstances on a permanent long-term occurrence as opposed to helping us all get through the pandemic and all its various implications.
Well, maybe you, and just quick, it's a follow-up statement, not a question, I promise, Mr. Chairman. You and I and Pat O'Connor can sit down and look at sort of the Attorney General's sort of letter and their path forward for this, and maybe we can come up with something there. Thank you.
Thank you. Chair, seeing no further questions from members of the committee, we want to thank those witnesses who testified in favor and in opposition on this bill. There being no further witnesses on this bill, that concludes our committee hearings for today. We thank you all. I believe there is a voting session tomorrow, and we'll see you before then on the floor. Thank you very much. We are.
There's not a voting session on Friday.
Oh, I'm sorry.
That is not a voting session. No problem.
Oh, sorry.
I don't want anybody to be
mistake.
confused and think they haven't got a voting list when we're not having a vote. The voting session is the normal